Hello and welcome to the 8th webinar in our Transition to Transplant series. Today we have Kate Gent and Ronalee Robert with us to speak about cystic fibrosis-related diabetes in patients with cystic fibrosis undergoing a lung transplant. At the end of the talk, there will be an opportunity to ask questions via phone or via the chat feature on the right-hand panel of the screen. Kate and Ronalee, thank you for joining us today, and I'll pass it over to you to start today's talk.
Thanks, Joanne. This is Ronalee, and
hi, this is Kate Gent.
And today I'm going to just start off the talk. I'm going to do the first half, and Kate will do the second. I'm just trying to advance the slides, and it doesn't. Oh, there we go. Okay, so this is our outline. I'm going to start with the first 2 points. I'm going to start off with a review of cystic fibrosis-related diabetes, and then I'll go into the pathophysiology and complications. And I'll go into a little bit of the clinical management, and then from there, Kate will take over and do special considerations, a summary, and our case scenario that we've included for today. Okay, so just for some background, CF-related diabetes is one of the most common complications in adults with CF. It's rarely seen in children. Only about 3% of the kids have it. The prevalence gets higher in adolescents at about 20%, and then we start seeing 40 to 50% of our adults with this complication. And it may be that due to inadequate screening, the actual figure might actually be higher. We do know that females have it more often than males, and it's also associated with the severity of their CF mutation. So pancreatic insufficient patients have it more commonly than pancreatic sufficient, and the most common is seen in those with delta 508. So this is kind of a busy slide, but I like it because it really outlines how distinct CF-related diabetes is from type 1 and type 2 diabetes. Just if we look in the column under CFRD, the prevalence is much higher than type 1 and type 2 in the population, 35%. It's a younger group of people that get it. Usually peak age of onset is early adulthood, 20 to 24. As we know, CF patients are usually normal body weight to underweight, so compared to type 2 diabetes, it's more common in obese patients. And then the biggest difference I find is that it's a relative deficiency in insulin. So in type 1, they have complete deficiency, and in type 2, it's very variable or just a partial amount of insulin deficiency. And we do also see insulin resistance, but it's usually not the major presentation. It changes depending on their infection or if they're on steroids, things like that. Another important thing to highlight is that it's rare for them to have ketones, and the A1C also can be a little bit unpredictable in terms of how it relates to the blood sugars. And the usual treatment similar to type 1 diabetes, it's insulin. And the last thing to really highlight is that people with CFRD do get microvascular complications, but macrovascular complications are rare. Okay, so the pathogenesis of CFRD, the mechanism really isn't that clear. There's a destruction of the architecture of the pancreas due to fibrosis and inflammation, and from that, they believe the beta cell mass is reduced. And that leads to an insulin deficiency. And as mentioned on the last slide, there is insulin resistance that can be related to chronic and underlying infections and associated treatments such as steroids, as I mentioned before. And so if you have a relative insulin deficiency, what's the problem for the person with CF-related diabetes? Why is insulin so important? Well, insulin is an anabolic hormone, and it's used to move protein from blood to muscle cells. And it also moves fat from blood cells that store fat. So this provides energy and allows people to gain weight and maintain weight, which is very important in CF. And some of the complications are related to the fact that there's a reduced insulin within these patients. So we know that the mortality rate is 3.5 times higher in patients with CFRD than those that don't have it. And this is related to the rate of their lung function decline, which is in proportion to how severe their glucose intolerance is. And And for those undiagnosed with CFRD, you can see weight loss occurring in the 4 years before they're actually diagnosed. As I mentioned before, they do have microvascular complications. 21% of them have retinopathy, 3 to 16% have nephropathy, and 5 to 21% have neuropathy. And as mentioned before, macrovascular complications are rare, so the usual mortality is related to their lung disease as opposed to heart disease, as seen in type 1 and type 2 diabetes. These slides don't advance very well. Okay, so this next slide we're talking about how does one diagnose CFRD in our CF patients. And because of the complications, specifically the weight loss and the lung function decline that can happen in undiagnosed CFRD patients, it's really important to start screening your healthy outpatients in your clinic. The oral glucose tolerance test is definitely the test of choice for diagnosis, and we base it on a fasting blood sugar of grade 7 or greater, or it can also be diagnosed after the 2-hour glucose test of a blood sugar of 11.1. A1C can also be used as a diagnostic tool. Values greater than 6.5%, equal to or greater to, can be diagnostic for our healthy outpatients. And also random blood sugars greater than 11.1 as well can be diagnostic. All of these, the first 3 tests should be repeated to confirm the diagnosis. And another way that CFRD can be unmasked is with G-tube feeds. You can base it on the mid feed, having a blood sugar greater than 11.1, or post-glucose feeds. We usually do 2-hour post as a diagnostic weight. And again, you need to confirm it on 2 separate nights. And if possible, if a patient, ideally, you should be able to confirm it with a lab measurement to confirm those values. Generally, if somebody's in hospital, that can be used as well. So leading to that, anybody who has systemic steroids or an acute illness, diagnosis can be based on high blood sugars that are sustained for over 48 hours. And again, it's the same criteria, fasting above 7 and 2-hour above 11.1. Again, it should be confirmed with lab measurements. And the last time that we can potentially diagnose CFRD is during pregnancy. It's based on a 75-gram glucose drink, but we make sure to include the 1 hour. So values above 10 at the 1-hour mark can also be diagnostic for CF-related diabetes. So the management, the general basic management of CF-related diabetes, the number 1 rule with our patients is not to restrict their diet. Because of their high energy requirements, needing 100 to 150% of the recommended daily calories, anytime that you restrict carbs, it can really reduce their energy input for the day and lead to weight loss. Insulin, as mentioned before, is the drug of choice. We generally start with meal coverage. Generally, people with CF, we unmask diabetes with the post-meal values. Occasionally, it starts with high random morning blood sugars. But the general rule of thumb for starting insulin is to use 0.05 to 1 unit per kilogram, with or without basal insulin, depending on what their morning numbers are like. Generally, we don't recommend oral agents. However, if there's safety concerns or a patient really is resistant to starting insulin, you can start on glucanorm. Generally, we start with a dose of 0.5 milligrams before a meal. And the mechanism of glucanorm is to push the pancreas to push out more insulin, so there is a risk of hypoglycemia, and patients need to be aware of that. You dose the glucanorm based on their 2-hour post blood sugars, and you can go up to 4 milligrams per meal with a total daily dose of 16 milligrams. If blood sugars are persistently above 10 post-meals, or an A1C is greater than 8%, then it really leads to the decision that you need to initiate insulin. And studies have shown that glucanorm may only be able to improve lung function and weight in the first 6 months, although there are cases where patients have been on it successfully for many years. And then the routine management of patients that do have diabetes, CFRD, it's recommended that they have quarterly visits with a specialized multidisciplinary team with diabetes and CF expertise. Again, treatment is insulin therapy, and it's recommended, if they're on insulin, to monitor their blood sugars at least 3 times per day. A1C should be measured quarterly with a target of less than 7, although this can be individualized for different patients. It may be higher and lower based on things like having a history of hypoglycemia or cognitive issues. You may want to shoot for a slightly higher target, and there's other instances where you would change the target. And we also recommend moderate aerobic exercise for more than 150 minutes per week. So one thing to keep in mind about the hemoglobin A1C and CF, CF patients have an accelerated red blood cell turnover, and it can cause an artificially low A1C. So for this reason, it's not a good screening tool, but again, as I mentioned before, it can be considered diagnostic if their levels are equal to or greater than 6.5%. So with the artificially low A1C, it can result in a misinterpretation of that CFRD is well managed. And also people who have been diagnosed with CFRD can have a lower A1C of 6.5%, but still have diabetes for this reason. So it's still really important to do quarterly A1C values and really watch for trends with it. And this is a bit of a busy slide, but we wanted to include it because it's actually a really great reference for the different types of insulin and their onset of action, their peak, and their duration. So it's a nice visual of the rapid-acting, short-acting, and the basal insulins, and so you can see how they compare. So we'd like to kind of keep that in our toolkit for people to refer to. We've also listed some of the names of the different insulins that are available right now. What's not included on this slide is there's a couple new insulins, Toujeo, which was just approved by Health Canada in 2015. Traceba was approved just this last August. It's a longer duration of basal insulin. It goes beyond 42 hours, so that's a new insulin that may be useful for certain people. And this slide I wanted to just go over typically which of the insulins on the last slide we would use in the situations where they best work. So basal insulin is administered for those patients that have an elevated fasting blood sugar. Generally, we administer it at night in order to help the morning blood sugars, although some patients do sometimes take a split dose morning and night in certain scenarios, or sometimes take it in the morning depending on where they're having issues with lower blood sugars or higher blood sugars. For those patients that have a G-tube feed, basal insulin doesn't have a peak, so NPH or N or even Humulin R can be used pre-feeds in order to manage blood sugars throughout the G-tube feed. And for those blood sugars that are high post-meals, it's recommended to use the rapid-acting insulins such as Humalog or NovaRapid. And generally, we recommend using carb counting, which I'll go into a little bit more detail. For those patients that have just an impaired glucose tolerance, there are some studies that are suggesting that Levemir, which is a basal insulin with not quite as long a duration as Lantus, can be used to help improve lung function if you do dose it mornings daily. The benefit of once daily injections also minimize the treatment burden for patients, may lead to reduced episodes of hypoglycemia, and also may not need to test blood sugars as often. And also, patients receiving corticosteroid therapy with high blood sugars may benefit from having NPH or N insulin because those insulins tend to have a longer duration and they have a peak later in the day, which is basically happening at the same time that the steroids cause increased insulin resistance. So I'm just going to go briefly into nutrition. As I've already mentioned before, diet restrictions may result in weight loss, so they're not recommended. Some patients need 4,000 to 5,000 calories per day for their diet in order to meet their calorie recommendations for weight maintenance or gain. There is an exception, though. We do have some patients that are newly diagnosed with diabetes that are actually well-nourished and have an excellent BMI. So there may be instances, if their blood sugars are just slightly high above meals, that we can minimize some of the really sweet candy and pop, things like that, and sometimes spreading the carbohydrates through the day so they still have the same volume of carbohydrates, but they're in smaller portions. We've sometimes been able to do this for some time, as long as they're able to maintain their healthy weight. And so this is just a picture of what a typical CF diet can look like. It's a lot of food, and we want to be able to give our patients flexibility to be able to eat a variety of different kinds of carbohydrates and different amounts of carbohydrates. So carb counting is really the best tool that allows our patients to use rapid insulin to adjust the amount of insulin they take based on the carbs they're consuming. And the basic steps of carb counting are really making sure the patients know which foods contain carbohydrates, those that will affect their blood sugars, and then learning how to have resources or read labels so that they know how much the total amount of carbs in their meal is. And from there, we work together with the patient to establish an insulin to carb ratio. And a typical starting dose for a lot of CF patients seems to be 1 unit to 15 grams of carbohydrates, but it's really based on their blood sugar levels. We work very closely with them to adjust this ratio so it fits and gives them that flexibility to eat whatever they like. And a few other factors that also affect patients' post-meal glycemia levels. One of the big ones is gastric emptying. We do have a lot of patients that have delayed gastric emptying, and that can be a real challenge in order to have their insulin match their blood glucose rise, because there is a delay if they're not digesting their food and it's not getting absorbed as quickly. If they take their insulin at the same time they eat their meal, they're often at risk for having a low blood sugar because blood sugar, the sugar from their meal hasn't actually hit their bloodstream in the same time that their insulin takes effect. So one of the challenges with this is we want to prevent the lows. So we sometimes have patients with this issue take their insulin at the end of the meal, and sometimes that seems to help out a lot. The other thing that can cause issues with blood sugar is patients' enzyme adherence. So if patients are malabsorbing their fat because they're not taking their enzymes, they can have actually a quicker gastric emptying. So sometimes and then you get a sharp rise in blood sugar. So it's important to also check into how patients are taking their enzymes, if they're taking an appropriate amount or if they're missing enzymes with their meals when they're having problems with their blood sugars. And G-tube feeds, I sort of alluded a little bit to how we manage them with our insulin or MPH insulin. And the way we decide whether or not they do need insulin with their feeds is to monitor halfway through their feeds and 2 hours post their feed. If we're finding that they're above target, then that's when we determine if they need to initiate insulin. Generally, we start with the MPH and hope that that covers the peak of the G-tube feeds. But at times it may be too slow to get into their system, and we need to add a slightly faster insulin at the same time. So again, you need to confirm that they're having high blood sugars on 2 separate nights, and then from there you start working out how much insulin they need. And definitely it can change based on the volume of their feeds, the rates of their feeds, those kinds of things. So it can be also a very challenging situation to work it out with our patients. And impaired glucose tolerance is this in-between before a person actually has full-blown CF-related diabetes. And sometimes it's transient. It can be due to a person having an underlying infection. But it's also an opportunity, if they do have impaired glucose, to act as an early intervention where you can start a piece of the education for future CFRD management. And it helps sort of ease them into the whole overwhelming load of managing diabetes. So what we do is teach patients to monitor their blood sugars, because they can be high in a glucose tolerance test, but when they eat at home, because it's mixed meals and it's not just sugar, the numbers can be quite normal. And so once a person learns how to do that, it's sort of the first step into, if they do become diagnosed with diabetes, it's the first step to learning how to manage diabetes. And if the numbers are okay, then we can just leave things. If they get sick, it's a good time to monitor again, but really just perform another oral glucose tolerance test and see. If their numbers are high, then a decision does need to be made for treatment. And as mentioned before, new evidence does suggest that a low dose of insulin sometimes can be beneficial for preserving their lung function. And again, annual oral glucose tolerance tests as long as the values are within normal limits. Okay, so this is where Kate's going to take over.
Thanks, Ronalee. So I'll just discuss briefly about CFRD monitoring and management during acute illness. When patients have ongoing pulmonary exacerbations or acute infection, they can have a marked increased insulin resistance. Their insulin requirements can actually increase by 2 to 4 times their usual. And so it's really important to monitor them closely and adjust their insulin appropriately. It's important to have good glycemic control generally, but especially with ongoing exacerbations, because it can enhance the response to antibiotics to control infection. And so, as I said, it's really important to adjust their insulin daily and very regularly. It's also important to know that it can take a bit of time for the condition to improve. It can be up to a month sometimes post-illness where the insulin resistance still is present and the amounts of insulin needs are higher. But usually, most often when patients return to baseline in terms of their infectious symptoms, when recovered, some will require less insulin and some may require no insulin at all when well, who are not normally on insulin usually. So I'm going to discuss pregnancy. As we know, many patients are living longer, and it's exciting. We're seeing many women having children. But with CF-related diabetes, we're very careful about monitoring this and doing a lot of pregnancy counseling beforehand to have the best outcomes for both the mother and the baby. So the CF Foundation guidelines have a really good list of recommendations for gestational diabetes and screening and treatment. So first off, it's always important when doing pregnancy counseling, and if someone's considering getting pregnant, to do a baseline oral glucose tolerance test. Hopefully, everyone does do one each year, but as we know, sometimes they're not done, or if a patient hasn't done one in a while, it's good to have an updated one to rule out CF-related diabetes prior to conceiving. Once pregnant, it's important to repeat an OGTT if it's not previously done within the past 6 months. And then again, we repeat the OGTT at the end of both the first and second trimester. We also do a 1 and 2 hour OGTT, as Ronalee mentioned. So this is a bit different than regular obstetricians and pregnancy management that do the 1 OGTT midway through pregnancy. So some patients will have questions, and it's good to just discuss this. So we like to do it at each trimester. And then after delivery too, we screen again at 6 to 12 weeks after delivery with just a 2-hour, 75-gram fasting OGTT. We know that there's an increased risk of developing CFRD post-delivery or in the future if a woman has had gestational diabetes. For those women with pre-existing diabetes, it is also really important to provide a lot of detailed education and recommendations about the target blood sugars and risks during pregnancy for both the baby and the mother. The target A1C is much more tight prior to conception, and we really recommend less than 7% of an A1C, and we try to do a 3-month trial with women, but the ideal target is actually less than 6.1%. It's important to provide intensive education and follow-up via phone, email, and in clinic throughout the pregnancy, and close monitoring, especially for nutrition and weight gain, and then management of glycemic control. It's recommended to refer to an endocrinologist that has gestational diabetes specialty, and working closely with the obstetrician or midwives that are caring for the woman. As Ronalee said, it's really important not to restrict calories, but cover the amount of carbohydrates appropriately with the amount of insulin for women so that they can maintain their weight. So just to go over the pregnancy targets, as they're a bit different than the usual targets that we recommend. The fasting blood sugar for women with who are pregnant with CFRD, it has to be less than 5.3. 1 hour post-meals is 7.8, and 2 hour post-meals is 6.7. So they are much tighter targets, and it's really important for regular blood glucose monitoring at least 4 times a day, primarily post-prandial, including some fasting, but it's the post-prandial that we really see sometimes fluctuating and needing insulin adjustments. We do expect a rise in insulin requirements as pregnancy proceeds up to 36 weeks gestation, but we do note that there's increased hypoglycemia, especially in the first trimester, so it's important to educate patients about that. Also, insulin requirements can be disturbed by hyperemesis or use of steroid therapy, so again, there'd be many adjustments made and important to monitor if a woman's having hyperemesis. So after delivery, as I mentioned, screening should take place again using a 2-hour 75-gram OGTT, approximately 6 to 12 weeks post-delivery. At delivery, it's important to note that if a patient has CFRD or gestational diabetes, they have a high risk of hypoglycemia immediately after delivery. We've had cases where a patient's blood sugar dropped to 1.2 immediately after delivery. So it's really recommended that we don't that women with CF do not have an insulin infusion. If anything, most of their insulin can be cut back and they don't need to take it, especially the basal insulin, but the rapid-acting insulin, of course, if they're eating is very important. But it's important to minimize any risks of hypoglycemia. For patients who didn't previously have CFRD, they may still need insulin ongoing, or they may not afterwards. And as mentioned, they still have a higher risk of developing CFRD in the future. So moving on to transplant, which is an important topic of today and related to CF-related diabetes. It's really important that we really provide a lot of education to patients before undergoing transplant, even referral and assessment and being listed, because of the increased risks after following transplant. Of course, it's the same treatment, that insulin's the main therapy, and for patients going towards transplant, the importance of nutrition and exercise is also needed to be highlighted. During the preparation phase for transplant and post-operatively, it's important that to know that to anticipate changes in insulin requirements due to corticosteroids and anti-rejection medications. This can often change quite dramatically. It's also important to educate about continuing to take enzymes because, of course, the patient still has CF, and for absorption, there's no need to stop taking enzymes, and this is really important for insulin absorption. The type of insulin, however, may change. So if a patient who has CF-related diabetes and who's on a regular insulin regime, this might need to change following transplant due to high prednisone dosing or other complications. And frequent monitoring is still very important, and we recommend up to 4 times a day with focus on the 2-hour postprandial blood sugars. There's also a lot of effects on, with suboptimal glycemic control, it can affect recovery and lead to ongoing infection if blood sugars aren't well controlled. Post-lung transplant, the effects of glycemic control are really related to post-transplant medications, as mentioned, including the corticosteroids and anti-rejection medications, and increased insulin resistance. The prevalence of diabetes increases quite a lot after transplant. In a study done in Toronto, 2005, it showed that the prevalence was 29% before, and increased to 50% of patients had diabetes post-transplant. And the median time of many of these patients developing diabetes was around 45 days post-transplant. So once again, it's important for patients being assessed and listed for transplant to be counseled about the risk of developing diabetes after transplant and the potential complications. So screening for CFRD post-transplant is very similar to the regular CF population. Fasting blood sugars, though, doesn't always reflect the postprandial blood sugars because of CF patients continuing to have a high-calorie, high-carb diet. So the postprandial blood sugars are very important to check. We always recommend self-monitoring, which many patients continue to do in hospital, but even after discharge, as we know that the increased rates continue up to months after transplant. Checking 2 hours post-meals is extremely important. And even years after transplant, we always still recommend doing an oral glucose tolerance test annually with the CF clinic after annual follow-up if they're not already on insulin therapy. And quarterly A1C monitoring is also standard of care. So some key points in summary about CFRD and related to transplant is that the management often is different than prior to transplant due to the effects of the corticosteroids and anti-rejection therapies. Rapid-acting insulin is usually still needed to cover meals with potentially adding basal insulin. However, with high-dose steroids, we found that many patients respond well to having NPH insulin to coincide with the effects of the prednisone, so once-daily dosing, usually or sometimes twice-daily dosing of NPH to match the steroids has been very effective. As health improves, though, and patients are increasing activity and the dosages of their medications is being lowered, there's often a reduction in insulin requirements, and often some patients don't require insulin any longer. Of course, it's important to continue taking pancreatic enzymes, and checking hemoglobin A1C every 3 months is very important for ongoing monitoring. Patient education is always important. So this is exciting to kind of share some of the new advances in monitoring devices. It's great that there's a lot of different, more mobile and advanced technology that can help prevent needing to do routine finger pokes, and that can be kept on for a longer duration, and that can be connected to devices using Bluetooth, so for improved monitoring. So the first picture on the top right is a continuous glucose monitor that we're seeing more and more of our patients using. These are 24-hour subcutaneous systems that are inserted subcutaneously, and they monitor the blood sugars over 24 hours and have high and low alarms. So the low and high blood sugar values can be set so that if a patient is starting to become hypoglycemic or having elevated blood sugars post-prandial, for example, that it can alarm to warn the patient. This is really good for helping understand different patterns and trends, and for education and self-adjustments of insulin. Bluetooth glucometers are great too, and we really like to use them as we can log into a remote system so that we can view patients' blood sugars from our office, and then be able to communicate with the patient rather than having to phone or email or send in blood sugar reports. And these are fairly new, and they're being used quite widely, and a really good way of monitoring blood sugars and be able to communicate with the healthcare provider. And then on the bottom right, this is a flash glucose monitoring system, which is also fairly new, that a subcutaneous port that can be put in for 14 days, and the meter is just swiped against it using a flash system. So this doesn't involve any finger pricks. There's no need for calibration, which is done with the continuous glucose monitor, and many patients are finding this is a really great alternative from a regular glucometer. And sorry, just to mention, with all of the advances and these devices, all of the CGMs and flash glucose monitoring systems can be wet, so patients can go in shower, bath, or swim with them. Just briefly, we'll also talk about the insulin pump, because this is also a very important advance for many of our patients who have been using insulin pumps that find them to be much more convenient and help them with their learning, especially with self-adjustments and carb counting. So to use an insulin pump, of course, you'd have to be approved and seen by an endocrinologist and a diabetes team to really review with a dietitian and nurse about carb counting skills, and you have to demonstrate to be able to carb count. But it does provide a lot of flexibility in someone's schedule, especially for people who are shift workers or on the go. It's a really good way of helping to administer insulin. It's more effective delivery of insulin, because instead of having a lot of separate injections per day, the rapid-acting insulin is in the pump, and they can just self-bolus directly through the pump frequently throughout the day. It allows for various basal rates, so for patients who might be treated with steroids for acute infection or who exercise at different times of the day or for work at different times of the day, they can you can set various basal rates to help adjust so that it can prevent hypoglycemia. And you can pre-program exact insulin-to-carb ratios for different meal coverage. It also gives instant feedback to help provide greater control and education. So this is covered by the provincial government, assuming it is signed off by an endocrinologist, and they can be replaced every 5 years, and the majority of the supplies are covered, but sometimes there is some individual out-of-pocket costs. So moving on, and to finish up, we just wanted to go over a case study. We had many we wanted to share, but we thought this one was really helpful in just putting things all together, and also with focus on transplant. So this is a 22-year-old female with CF who was assessed for lung transplant in 2015 and then eventually listed in 2016. She's pancreatic insufficient. She has a history of impaired glucose tolerance on one oral glucose tolerance test, but not required insulin before this time. Her initial admission to hospital was in August 2015 for about 5 weeks, and at this time she was started on high-dose prednisone, 50 milligrams in the morning. Previously to the admission, that was tapered down to 35 milligrams in the hospital. Her blood sugars on admission were above target, and her fasting were usually between 6 to 8, so just slightly above target, and her 2-hour post-prandial blood sugars were between 8 and 13. Her hemoglobin A1C was 7.2%. And so she was started on intermediate-acting NPH, 16 units in the morning, to coincide with the 35 milligrams of prednisone in the morning. And she was also given a correction scale with Humalog for her meals. She was taught by our dietitian how to carb count in hospital, just in case she did need to stay on insulin, with the hope that she would come off of it. But she was eager to learn, so she quickly picked up how to carb count appropriately. So then she was discharged in September, but she was very motivated and communicated regularly with our team. And over email and phone 2 weeks later, we spoke to her, and her 2-hour blood sugars were still quite elevated at 10, usually 10 to 15. And so we increased her NPH to 20 units. She started meal coverage using a insulin-to-carb ratio of 1 to 20, and she titrated this over the next several weeks with a bit of our help to 1 to 20 with breakfast and dinner, but 1 to 10 with lunch, as she needed a bit of a tighter ratio for her lunches. So then mid-November, about 2 months later, her prednisone was fully tapered, and so was her NPH in conjunction with a decrease in the steroids. However, she still continued on the Humalog as she needed it with meals with the same insulin-to-carb ratios. Her hemoglobin A1C, when checked again, was 6.4%. And then mid-February, 3 months later, she still needed the Humalog, but she was able to adjust her ratios to use 1 to 20 across the board, including her lunch. And her hemoglobin A1C had come down to 6%. Then in June, she had her lung transplant, and in hospital, she was started on a correction scale, and her blood sugars kind of remained consistently above 10. So she was instructed to liaise with our CF team as an outpatient, and especially for long-term management of her diabetes. So 1 week after her discharge, when she was not on any insulin, her fasting blood sugars were 7 to 10, and her afternoon, the kind of dinner values were 16 to 17, and then at night before bed she was still elevated at 14 to 20. So we restarted her on NPH 5 units in the morning and increased this by 1 to 2 units every few days to be safe and slowly titrate to prevent any hypoglycemia. She also restarted on Humalog using a 1 to 15 insulin-to-carb ratio across all meals. So then she got things under control, and then unfortunately, shortly after in July, she had acute rejection and needed pulse IV steroids. So at this time, her blood sugars increased up to 15 to 17, and she needed a higher dose of NPH, 20 units with the steroids, and then this was tapered. Once she was back on her maintenance prednisone, we added just NPH at night as well because she had elevated fasting blood sugars. And this is common where sometimes patients will require a small dose of NPH at night to provide more 24-hour coverage. In September, at her 3 months post-transplant assessment, when she was in Toronto and we saw her, her prednisone was 20 milligrams in the morning and her cyclosporin dose was 20 milligrams twice daily. Her fasting blood sugars were 8 to 10, so still above target, and her evening were 15 to 18, and her HS before bed blood sugars were 10 usually. She was on an NPH 15 units in the morning and 5 units at night, so we increased both, and then we continued her on a 1 to 10 insulin to carb ratio, and her A1C at this visit was 6.9%. 2 weeks later, through email and as an outpatient, she was doing very well. Her fasting blood sugars were just only slightly above target, 7 to 8. Her PM blood sugar values were 8 to 10, and at night she was 8 to 10. So overall, she did very well, but it was you can see it was a lot of communication and regular adjustments and monitoring of her as she was unwell in hospital, then went through transplant, and then post-transplant with some complications. So that's the end of the case study, and we just wanted to finish up by providing some conclusions and overall summary, highlights of what we discussed today. So just first off, as you can tell from especially Ronalee's introduction and overview, CFRD is common in CF, but it's a very distinct form of diabetes. We like to say it's a class of its own. Instead of type 1 or type 2, we call it a class of its own. The hallmark is insulin deficiency, and insulin resistance also can occur. The prevalence increases with age, with up to 40 to 50% of adults having CF-related diabetes. Microvascular complications do occur. However, macrovascular complications are very rare. And the management really does require a multidisciplinary approach with CF expertise. Insulin is the treatment of choice, although there have been some instances where oral agents, well, primarily just gluconorm at this point, has been used, but long-term and ideally insulin is the treatment of choice. Early diagnosis and effective treatment can improve lung function and nutrition and prevent short-term and long-term complications. There's also been many advances in glucose monitoring systems and different insulin devices. And there's potential benefit of new oral agents and lots of new medications that research is still much needed, but it will be interesting to see in the future what happens and if there's new potential diabetes therapies that would be suitable in CF. So I think that's the end. Here's some references, and throughout the presentation too, and this will be posted, but there's some really great resources that we'd like to share, especially the CF Foundation Diabetes Education Manual for Patients and Families. There's a lot of good general information in that. It is quite long, but it is important to share with families, but also for healthcare providers. And Dr. Tony Moran, who's an endocrinologist in the U.S., she has written really great clinical guidelines about CF-related diabetes, and there's an updated copy as well that's a short summary, so that's a good resource to look out for as well. I think that's it. So if there's any questions right now while we're live, we'd be happy to take some, and otherwise I'm pretty sure this will be posted in the near future so that you can share with your rest of the team.
Thank you, Kate and Ronalee. We're now open for questions, as Kate said, so you can use the raise the hand feature, and I could unmute you if you'd like to ask any questions over the phone, or you could type your question in the chat or Q&A box, which is located on the right-hand side of the screen. So I'm not seeing any questions come in. There is one comment from Tracy Goyers, and she just says to say thank you for an excellent presentation, and she looks forward to sharing the link with her team. The webinar has been recorded, as Kate mentioned, and I will be posting it up on the healthcare section of CF Canada's website, and that's under the Transition to Transplant tab, and the recording should be available next week. And you can also see a list of our upcoming webinars on our website, and the registration will be emailed as future webinars are scheduled. So thank you again to Kate and Ronalee, and to everyone that attended today's session. Bye.
Thank you, everyone. Thanks, Joanna.
Bye. Thank you.